Hi, everyone. Welcome. Thanks for joining. We will wait just a minute to let everyone trickle in. In the meantime, please feel free to introduce yourself in the chat. Thanks for joining, everyone. Glad to see everyone here. We'll wait just a minute to let other folks trickle in. Okay, it looks like we have a great number of participants, so we'll go ahead and get started. Hello, everyone. Good morning or good evening, depending on where you are. Thank you so much for participating today. We're thrilled to welcome you to session 8 of the Reproductive, Maternal, and Newborn Health in a Changing Climate course. The topic of today's session is supply chains, medication access, and RMNH during climate disruption. My name is Rachel Sorcher. I'm the Senior Global Health Officer at International Medical Corps, and I'm so pleased to be your moderator for today. So let's get started. We just want to thank all the partners who are involved in putting this course together, including Global Consortium on Climate and Health Education, the International Confederation of Midwives, UNICEF, and my own colleagues at International Medical Corps. This is a quick reminder that simultaneous interpretation is available in French and Spanish. So please just select your preferred language using the globe icon in the Zoom toolbar. And also English closed captions are available by clicking the CC button at the bottom of the Zoom window as well. So for those who are joining us for the first time today, or a refresher for those who have joined our previous session, the course overall focuses on recognizing, assessing, and managing climate-sensitive health risks affecting reproductive age, pregnant, and postpartum patients, including risks related to extreme heat, air pollution, and vector-borne diseases, especially in low and middle-income countries or low-resource settings. Here's a reminder of the course schedule. We have 2 trainings left after today on September 1st and September 8th, so please be sure to join us then to learn more about climate-ready primary health care facilities, as well as self-care, mental health, and occupational resilience for frontline workers themselves. As for the goals of today's training, by the end of the session, we hope you'll be able to identify climate vulnerable supplies and maternal care and pharmacological substitutions, learn strategies to prevent postpartum hemorrhage in facility and community level births, maintain safe labor, birth, and infection control when sterile supplies, transport, or power are disrupted, prioritize and ration medications during stockouts, explore preparedness and response plans, and describe aspects of patient-initiated self-care during climate emergencies. To receive a certificate of participation from the GCCHE for this training, you must attend at least 7 of the 10 sessions and pass the final exam with a score of 70% or higher. The exam has to be completed using the same email address that you use for your Zoom attendance or what you signed up for. And the exam link will be sent on the final day of class through both email and WhatsApp and will close on September 15th. And just to give you a sense, the final exam includes about 25 multiple choice and true or false questions, and you should complete that in one sitting. As for some logistics today, our session is 75 minutes. We're going to pack a lot of great information into today, and we will get to talk to expert lecturers and also case study presenters. And at the end, we'll have a question and answer period. We ask that you please kindly submit questions through the Q&A box instead of through the chat. This will ensure that our team can take note of them, and once the lecture begins, we'll probably disable the chat to allow focus to remain on the presenters. But the recordings, the slide decks, and additional resources are available on the course website after today's session. We encourage you, if you haven't already, to join the course's WhatsApp group for updates and information from the planning team. And I believe that the link is also available in the chat right now. So finally, this is a plug to check out some of the other incredibly useful resources that GCCHE has to offer, including the Nursing Climate Resources for Health Education section. The team is currently looking for slide deck writers and faculty advisors to both create case studies and slide decks as well as provide expert feedback. So there are many different ways to become involved. If you're interested, you can scan the QR code or reach out to the team to get in touch. Without further ado, then, it's my absolute pleasure to introduce each of our experts for today. We have Dr. Tandi Sabindi, Dr. Yazid Ayasra, and Dr. Francis Ojenyu. Dr. Tandi is the Policy Research Fellow at United Nations University International Institute for Global Health. Dr. Tandi is a midwife, nurse educator, and health systems researcher with an MSc in maternal and child health and midwifery, and has a PhD focused on health workforce capacity building and climate change and health. At UNU Global Health, she works at the intersection of climate change and health, health systems resilience, workforce capacity building, adaptation policy, and gender responsive climate action. Her work seeks to strengthen climate-resilient health systems and advance equitable health outcomes by integrating health into climate policy and adaptation planning. She also serves on the board of the Climate and Health Society. We also are happy to welcome Dr. Yazid Ayasra, who is the Director of Health Systems Applications at International Medical Corps. He's a health informatics specialist, a full-stack developer, and a licensed medical doctor. He plays the role as head architect for International Medical Corps health informatics tools, systems, and applications. He is the head developer and system analyst for PIMS and a proven performer in software database architecture development and design within the healthcare sector. And certainly last but not least, we're happy to welcome Dr. Francis Ojenyu, who is the Senior Sexual, Reproductive, and Maternal Health Research and Innovation Manager. He's a medical doctor, public health specialist, and SRHR advocate with over 9 years of experience in sexual, reproductive, and maternal health programming, research, and innovation. He holds a medical degree from the University of Maiduguri, and master's in public health from University of South Wales, and a master's degree in health planning and management. Currently with the International Rescue Committee, or IRC, he's spent the last 8 years advancing health solutions for underserved populations and humanitarian and hard-to-reach settings across Nigeria. So thank you to our presenters and for joining us. I'll now hand it over to our first presenter, Dr. Tandi, to get us started.
Thank you, Kathleen, for the kind introductions. I'll now move on to start my presentation. Welcome everyone to today's session, and thank you so much for joining us in our session entitled The Supplies Chains, Medication Access, and Reproductive Maternal Neonatal Health Care During Climate Disruption. So why do supply chains and medication access matter during climate disruption? This is because the climate shocks can turn manageable maternal complications into life-threatening emergencies when essential medicines and supplies are disrupted. The floods, cyclones, power failures, and supply disruptions can compromise medicines, blood supplies, the cold chains, and access to skilled care. So for women experiencing, for instance, postpartum hemorrhage, eclampsia, or sepsis, these disruptions can be critical. Thus, climate-resilient health systems need to protect continuity of essential maternal health care during emergencies. And why does this matter in the newborn care? Because we cannot talk about maternal health without the newborn care. So this is because climate change is increasingly becoming a newborn survival issue. We already have millions of neonatal deaths each year, and with prematurity being the leading cause, and the evidence shows that extreme heat during pregnancy is associated with increased preterm birth risk. Climate shocks can therefore compound these vulnerabilities by disrupting electricity, medicines, and supplies, as well as skilled care. So climate resilient health systems they're not simply about preparing for disasters, but rather they are also about protecting the newborn lives. So these are the objectives that are going to guide us in today's session, which have already been talked about by Russia. All right, so to begin with, we need to identify maternal care supplies that become particularly vulnerable during climate-related disruptions. So the risks, they vary by commodity. We have, for instance, oxytocin and the blood products that are particularly critical because they depend on reliable cold chain systems, while antibiotics, magnesium sulfate, and vaccines can be affected by supply chain, equipment, or storage disruptions. So this also highlights an important resilience opportunity that not all commodities have the same climate vulnerability. For instance, we have heat-stable options such as misoprostol or carbetocin, or as well as the cyanopress, that can provide greater resilience cold chain systems when cold chain systems are unreliable. So thus, maternal services require both protection of vulnerable supplies and a deliberate planning for appropriate heat-stable alternatives. So for the newborn care, some supplies are highly dependent on electricity or the cold chain systems. For example, we have the radiant warmers and the incubators that depend on reliable electricity. So a power outage, for instance, during extreme climate weather, it can quickly predispose a preterm or a low birth weight baby to hypothermia. We also have vaccines such as BCG and hepatitis B that require appropriate cold chain storage. So a prolonged refrigeration failure that can also result from an extreme climate weather condition. It can compromise their potency. And in the case of birth dose of hepatitis B vaccine, for instance, it can potentially result in a missed time critical vaccination. And looking at the other supplies, such as neonatal resuscitation equipment, these may not necessarily require electricity, but they can become unavailable when transport and supply chains are disrupted. So we need to know that climate resilience requires us to protect both the infrastructure and the supplies needed for the newborn care. Now, as we move on in our session today, I would want you to picture yourself in this situation. Imagine that you are the only midwife on duty, and overnight, a cyclone has cut off road access to the referral hospital. Electricity has failed. The refrigerator storing oxytocin is no longer functioning. The nearest center is 4 hours away. A woman has just delivered and suddenly develops severe postpartum hemorrhage. You have limited supplies, no electricity, and no immediate access to the referral hospital. I would want you to pause and think about what would be your first action in this scenario. So we then move on to look at postpartum hemorrhage, which is the routine management of postpartum hemorrhage in a health facility. It highlights the active management of the third stage of labor, that is the administration of the uterotonic immediately after birth, with oxytocin being the first choice and the heat stable carbetocin or misoprostol as alternatives. So there is the controlled contraction after uterine contraction and placental separation, as well as uterine massage after placental delivery, with regular assessments of uterine tone during the first 2 hours postpartum. So this shows that timely evidence-based and evidence-based prevention measures at the facility level can reduce the risk of severe postpartum hemorrhage and maternal death, particularly when appropriate uterotonics are available. So here we need to address a practical problem during a climate-related disruption, such as what do we do when oxytocin can no longer be reliably refrigerated, like as in the case that I've just given. The key principle is that the appropriate uterotonic that is available and can be safely stored is more useful than an ideal medicine that cannot be maintained properly. So oxytocin, it remains the preferred option where reliable cold chain storage is available. But where that is compromised, there has been a scientifically proven heat stable carbetocin and the misoprostol that can provide the alternatives, the postpartum hemorrhage prevention, with different storage requirements and clinical characteristics. So the important message that the substitution should be planned before an emergency, and the facilities, they need clear protocols for identifying compromised storage and switching to an appropriate alternative and monitoring women closely. And importantly, if postpartum hemorrhage develops, active postpartum hemorrhage management must begin immediately. That is, we give the uterotonic. If the first drug of choice, oxytocin, is not available, then there is the misoprostol plus an antifibrinolytic, such as the tranexamic acid, within 3 hours of birth, alongside the resuscitation and the treatment of the underlying cause. So we need to take note that the heat stable carbetocin is only reserved for the prevention of postpartum hemorrhage, but not for active management of postpartum hemorrhage. Having said that, there are other non-pharmacological interventions that can be used when medicines are unavailable, ineffective, or while definitive treatment is being arranged. So some interventions, they require little or no equipment, such as the bimanual uterine contractions, while others, such as the balloon tamponade, it requires basic equipment. So in a severe hemorrhage, aortic compression or a non-pneumatic anti-shock garment can help buy critical time during stabilization and transfer. So we need to ensure that facilities need to prepare for these non-pharmacologic options because power, medicines, supplies, and referral pathways may be disrupted, especially in the era of climate change that we're living in. So in managing eclampsia, which is the second leading direct cause of maternal death, magnesium sulfate remains the first-line treatment with close monitoring for toxicity and calcium gluconate on standby as an antidote. So if magnesium sulfate is unavailable, alternative anticonvulsants such as diazepam and when necessary, the phenytoin may be considered according to the applicable local protocol. So you need to be aware of your local protocol on the substitution of these drugs. And you then also need to manage blood pressure, which has to be controlled to reduce the risk of stroke, while definitive management requires delivery once the mother has been stabilized. Thus, this brings us to the recognition that trained staff and essential backup medicines are contingency plans for the treatment of eclampsia to continue even when normal supply chains are disrupted. And in the case of maternal sepsis, this is a time-critical emergency that requires early recognition and prompt management with the first-line intravenous broad-spectrum antibiotics where feasible, with an alternative to oral regimen only when IV access is unavailable. And the WHO's management of maternal sepsis in low-resource settings identifies the first M approach that ensures clinicians treat sepsis rapidly and systematically. So the first M, it also reminds us that maternal sepsis is not just about giving antibiotics, but it is about rapid resuscitation with IV fluids, and it also involves eliminating the source of infection. So you need to identify what could be causing this maternal sepsis. And there is also need for continuous monitoring closely and to escalate whenever the maternal condition deteriorates. So this structured approach of the first M, it helps maintain quality care even when the resources are limited, which can be in the case of climate emergencies. Now, moving on to look at safe labor and birth when supplies are disrupted. So there is also a need to maintain sterility when the resources are also limited. So if sterile supplies are limited, facilities may need contingency measures, such as appropriate antiseptics and alternative methods for ensuring sterile instruments. And during power failures, there is a need for basic tools such as a torch or a solar-powered light, a manual blood pressure device, and a fetal monitoring equipment to help maintain essential care during power failure. And when transport is disrupted, there is a need for bed waiting arrangements that can be waiting homes in the community or within the health facility itself. There is also a need for alternative communication systems, such as SMS or radio alerts, that can help the community health workers to ensure that women access care and enable timely referral when emergencies arise. So a useful clinical principle is to have practical contingency plans before a disruption occurs, rather than only improvising when emergency has already happened. So to bring together the practical contingency measures for time-critical reproductive, maternal, and neonatal healthcare emergencies, that is the postpartum hemorrhage, eclampsia, maternal sepsis, as well as the newborn sepsis. The emphasis is on maintaining continuity of life, that is, saving care when climate shocks disrupt the medicines, the equipment, electricity, transport, or the referral systems. So the approach is to pre-position essential medicines and supplies and protect them from climate hazards, ensuring that multiple staff are trained and are able to respond, maintain alternative treatment, and supportive care options. And you should also ensure that you have a reliable referral and communication arrangements. And you should also take note that preparedness must extend beyond having medicines available. Therefore, facilities need to be able to recognize deterioration. They need to act quickly. They need to monitor, stabilize, and if they cannot stabilize the patient, they should find means of transferring patients even when normal systems are disrupted. So now looking at during the stock outs, which can be the case when your facility has been cut off from the supply chain, you need to prioritize medicines. So the principle that should guide the allocation should be based on clinical urgency and the risk rather than first come, first serve. So looking at priority one, these are the medicines that cover immediate life-threatening conditions. So these medications should be used regardless of the remaining stock to manage cases such as active postpartum hemorrhage, eclampsia, septic shock, and emergency surgery. So then we have the priority two, which covers interventions that are not important but not immediately life-saving. For instance, prophylactic antibiotics for cesarean section. So while priority three includes care that can safely be delayed, substituted, or rescheduled. So on priority three, we have routine vitamins or nutritional supplements. So what we need to then take note as caregivers is to ensure that every rationing decision should be clinically justified and documented while agent resupply and referral are reactivated. So now this is a practical minimum reproductive maternal neonatal healthcare emergency kit that is designed to maintain essential maternal and newborn care when climate-related disruptions affect normal supply chains. So the kit brings together the uterotonics, eclampsia medicines, the antibiotics, the newborn care, and basic monitoring and communication tool. So the kit should be packed, protected from hazards such as flooding. So you should ensure that wherever you're putting your kit, it should be in a position where even if the health facility is to get flooded, this emergency kit will still remain dry and usable and readily usable. So you need to also protect it from heat, and it should be readily accessible in the delivery area so that the essential care can continue even when routine supplies or referral systems are disrupted. So another point to take note of is you do not need to only have this emergency kit being located in maybe your only delivery room. You can have several emergency kits that can be then stored in several places within the health facility, so that in case if there is failure to access one area where there is this emergency kit, you will definitely be able to access it in another location within the health facility. So having talked about this now then leads us to how do we maintain reproductive, maternal, and neonatal healthcare services when climate events disrupt normal health operations? So the first step is to anticipate the risk through hazard mapping and early warning systems, particularly by identifying women who may need early referral. So as a healthcare practitioner, you need to know your community. You need to be able to identify women that are at risk when there is maybe a predicted climate hazard that has been predicted, or maybe you are in a monsoon season, then you should be able to identify women that are at risk. These are, for instance, women with preeclampsia, women with previous postpartum hemorrhage or placenta previa, so that you provide any referral protocols before this climate hazard can occur. And you also need to ensure that your healthcare facilities are linked to weather services alerts so that you get the first-hand information about an approaching climate hazard. So we also then need practical alternatives, such as birth waiting homes that can be community-based and manned by a trained community health worker, or this birth waiting home can be within the healthcare facility itself. And you also need to provide mobile outreach services when transport or facility access is disrupted, especially post an extreme climate event. So there is also a need to integrate community health workers with the midwives to ensure that they provide support through early recognition at community level and provide at community level intervention as well as communication while ensuring supplies are pre-positioned and the referral pathways remain active. So in as much as we need to provide this minimum emergency kit in our health facilities, we also need to take into consideration our trained community health workers to also have the community appropriate emergency kit that they can use in case of a delivery. So in climate emergencies, they can also disrupt access to routine sexual and reproductive health services, including family planning. So self-care approaches can then provide an important layer of resilience by allowing people to maintain access to contraception when healthcare facilities, transport, or supply chains are disrupted. So this can include maintaining a supply of oral contraceptives, access to self-injectable contraceptives, such as the Cyanopress, access to emergency contraceptives, as well as the condoms. Importantly, these methods also need to be stored appropriately, particularly during extreme heat and other climate-related disruptions. So when you are dispersing these self-care medications to women, you need to also emphasize the importance of making sure that these are protected from direct heat, moisture, or any other extreme temperatures. So what we should also emphasize during the provision of these self-care medications to women is that self-care should complement but not replace health services to ensure that communities maintain reproductive autonomy and continuity of contraceptive access during emergencies. So self-care prevention at home and at community level. So this prevents postpartum hemorrhage when climate emergencies disrupt access to healthcare facilities. We have the oral misoprostol, which provides an important alternative for postpartum hemorrhage prevention where there is no skilled provider. So this oral misoprostol can be given to a trained community health worker to provide to the woman during the time of need when the access to the healthcare is disturbed. So this requires more than simply providing the medicine. So the communities need advanced provision, appropriate distribution, education on recognizing heavy bleeding, and clear instruction on when and where to seek emergency care. So the birth companions can also be taught appropriate supportive measures, such as the uterine massage to encourage a contraction to prevent postpartum hemorrhage. So importantly, we need to emphasize to our communities that self-care has limits. It is not a substitute for skilled care or emergency referral. Sorry, we should ensure that our communities are aware that self-care has limits. It is not a substitute to skilled care or emergency referral. So these limitations, they need to be clearly communicated so that women and families understand the need for appropriate professional care. So heat exposure can compromise the medicines without any visible change in the product, and this is sometimes overlooked. So looking at this presentation here, so these are the storage requirements and the heat sensitivity of commonly used reproductive maternal, neonatal, and healthcare medicines that include oxytocin, misoprostol, and the contraceptives. So some medications, they require strict temperature control, while others are more heat stable and can therefore provide important alternatives in climate vulnerable settings. So facilities need to know which medicines are temperature sensitive, protect them from heat and moisture, and use appropriate storage and stock management practices. So to bring together the central message of the session, what does climate resilient reproductive maternal neonatal healthcare look like across the health system? So the climate shocks can disrupt every part of maternal care, that is from medications, electricity to supply, transport, and skilled personnel. But these disruptions do not have to become a preventable harm. The resilience approach is to anticipate risks, pre-position essential supplies, protect critical infrastructure and medicines, maintain essential care, train and drill the workforce on what to do in case of emergency, and the referral pathways. So the climate resilient emergency kit brings these elements together. And ultimately, resilience means being prepared before the climate shock occurs so that women, the newborns, and the families can continue to receive timely and safe care when the health system is under stress. So if we are to bring the session down to what this means to us as health workers, there are 6 things that each practitioner needs to remember. The first one being, know your climate vulnerable supplies and anticipate the shortages. You need to prepare before a disaster rather than responding only after a disruption occurs. And you need to also remember that using non-pharmacological interventions has an important life-saving option when medicines or equipment are limited. There is also a need to recognize self-care as part of clinical care where appropriate. Ultimately, supply chain resilience is not only a procurement issue, it is part of our responsibility as clinicians to maintain self-reproductive maternal, neonatal, and healthcare during disruption. So to end this session, I would want to leave this with you that every maternal and neonatal death prevented in a climate emergency is a testament to a clinician's preparedness. So the supply chain resilience is a clinical skill. You need to learn it, you need to practice it, and you need to teach it. Thank you.
Thank you so much, Dr. Tandy, for laying this out so clearly for us. Really great practical guidance that we can be using immediately and planning and preparedness. And I think the principle you shared that the uterotonic you have that you can keep is better than the ideal drug you cannot store really well encapsulates the heart of your presentation. So thank you so much.
Thank
We
you.
will now move to our first case study from Dr. Yazid. Over to you.
Thank you, Rachel. Thank you very much. Allow me to share my screen. Okay. Can you confirm that my screen is visible?
It is, yes.
Perfect. Well, thank you very much again. Excellent presentation. So I get a little bit chatty when the topic is supply chain, but I'll do my best to keep it at 10 minutes so that the next case study also has enough time to cover the topic. This would basically discuss the concept of what happens when physical pathways fail, and how can data-enabled supply chain basically mitigate some of the climate-related risks that we face on a day-to-day basis. So the supply chain typically has two pathways, but often perceived to have one, which is the physical pathway. That is the actual pathway where commodities move from the suppliers, manufacturers, into the central warehouses and stores, all the way to the county and regional warehouses or distribution centers, and to the health facilities where you guys would be using all of these commodities that are life-saving and important to deliver the care that we at a quality level that is sort of sustainable in these primary healthcare centers. But that pathway is often sort of coupled by an informational pathway that gets neglected sometimes, which is the fact that every item dispensed, every time oxytocin is used, that should trigger a chain reaction of information that moves back through an informational pathway all the way back to the supplier. The problem that we currently face is that these information pathways do not usually exist in a sustainable manner that allows us to be resilient when a climate shock happens. Typically, if we have the information we need around the location and their level of consumption, the prospective cases that this location is going to address, we should be able to rearrange resources in the case of a climate shock in a way that allows us to ensure the continuity of service. When this data doesn't exist, then that means that we would basically go through the typical physical pathway of trying to order more commodities, which obviously that pathway would have been affected by that climate-related shock. So during disruption, the physical pathway may become slower, may get interrupted. You may have physical barriers that would prohibit the movement of a commodity from upstream supply chain all the way to the last mile. But if we have an informational pathway that is well established, then we would be able to sort of create alternatives to find solutions to those issues a little bit more creatively without having to go through the standard route. So when a climate shock happens, it sort of triggers a supply chain reaction. Um, it starts with a physical disruption, right? Let's talk about the floods in Kenya 2024. The theme of the problem was basically closed roads because of floods. But um, the actual issue that happens in the supply chain hits a little bit deeper than an intermittent or a temporary blockage in the supply route. What happens is a cascade, a self-destructive cascade, really, that long lasts the actual climate shock. So it starts with a climate disruption that is unfortunately part of reality now, that a lot of these countries are having to face some of these climate related shocks. But then what happens is that facilities and operators at facilities like midwives as yourselves would basically face uncertainty that creates a type of a behavioral change that that leaves us all sort of in a way that we're trying to overprotect our supply chain. So what happens often after a climate-related shock is that we see a spike and an increase in order rates and in replenishment rates and in buffers to try and sort of hold stock in locations to mitigate the current or the ongoing emergency. That problem, or the problem with that premise, is that this distorts the entirety of the demand signals that should flow between facilities, regional stores, central stores, all the way to suppliers, redistributors, and manufacturers. And what happens is that there is a phenomenon that is called the bullwhip effect, where the order that is being submitted throughout that particular phase is sort of amplified as we go through the supply chain, almost always resulting in significant waste and significant cost increase of the sort of the resupply exercise that would have typically been resolved should we have had information about where can we source these commodities without actually buying them. So after these precautionary orders sort of get submitted, what the supplier sees is a spike in demand, an increase in demand, which sort of increases the manufacturing or the redistribution pathways on that end to ensure that they would be able to sort of sustain that market. And the problem that we always see is that the floods or the roads would be cleared in a few weeks, but the problems and the stockouts and the overstock and the expiries would long last that climate-related shock, and it leaves the supply chain in a traumatized status, which would basically affect later on in subsequent climate-related events due to that effect. So typically, when sort of a climate shock happens, our intuition is let's just send more stock. Let's just try to pull as much stock as possible from the physical pathway that we all know exists. Let's order from the regional store, and the regional store would have the intuition to order from the central store, and then the central store to buy from the market. We typically, that is the first option. That's how you can sort of resupply. But the problem is that this route becomes extremely unpredictable, becomes quite longer and inefficient due to the effects of that climate events. The problem is you would find significant pressure applied on that particular route, resulting in sort of an increase in sort of in demand as well as the subsequent lead times to fulfill that demand. And should we have the informational pathway established and the data that we need in terms of the consumption of these facilities, what they have in stock, what is available, then we would be able to sort of mitigate the issue by moving commodities in locations that are close by to try and mitigate that issue. So I'll be talking about a specific example where we attempted that and where we're going with that. But the intuition for every midwife out there, before moving stock further and before trying to pull stock from the central level, let's think about how can we redistribute resources a little bit smarter from within the same area or region where possible. And when we have that visibility, it obviously will reduce the unnecessary exposure that we have. So currently, most of our supply chains are reactive. Unfortunately, the signal to resupply or the signal to resolve an issue happens or takes place after the shortage or the stockout happens. So when we're out of oxytocin, we try to sort of order some oxytocin or try to source some oxytocin through the supply chain into our facilities. That creates a lot of emergency requests, and we see that often where facilities have a established resupply cycle of 45 days or 3 months, but at the same time, they have ad hoc orders that far exceed the regular orders that they typically submit. At the same time, that creates, in a climate-related event, a lot of demand on emergency transport. This demand would basically result in an increase in transportation cost, a strain on the actual transport system, let alone the actual blockade that takes place in a case of a flood or in the case of a climate-related event that could affect the routes. So being reactive is sort of in a certain way the worst possible way for us to manage our supply chain, especially in an ever-changing climate, and especially with in locations that are most affected by these sudden disruptions. So we're seeing a lot of different health systems transition into a responsive manner, or a responsive setup, where they basically have the signal arriving before the stockout actually happens, but with a short lead time. That definitely helps us to improve, but the hope is for us to be a little bit more anticipatory. So we pre-position stock, we ensure that we are ready for that climate event before the climate event actually takes place and actually causes disruption and causes a decrease in the quality of care that is being provided. So the objective for us when trying to sort of render a more resilient supply chain is not to sort of predict every climate-related event, every flood, every time there is going to be a heat wave, but for us to have enough information that would allow us to react and react timely whenever that disruption takes place and happens. And that's where systems and data sort of comes into play, into how can we mitigate these issues. So I'll be talking about the Kenya floods in 2024. That was quite an interesting incident. Unfortunately, 267 were killed, with hundreds of thousands that have been displaced. It was quite a severe incident. And just earlier that year, we had deployed a software that is targeted towards digitizing the supply chain and moving consumption signals back to the central level uh, um, in a specific county. It's called the McQueeney County in there. So McQueeney is a dry county. They were not really affected by the floods themselves, but the issue is that most of the suppliers that would supply a specific county reside in Nairobi and reside in other locations that are heavily affected by this climate-related event. So what happened in that particular context is that the supply chain got severely disrupted. Basically, a complete interruption of resupplies actually took place. And the problem is that facilities there had a monthly resupply cycle, meaning that they resupply or they replenish every month based, and they always forecast for their demand for the next month. So after that climate shock, they weren't able to source commodities directly from vendors, since vendors' warehouses are sitting in Nairobi and vendors are overstretched. Some of them are actually worried about water leaking into their own warehouses and not being able to fulfill orders. And they've had a solution. They have had a data structure that allowed them to support the shuffling of inventory among health facilities themselves. So what happened there is that we've run an analysis and come to find out that about 67% of the stockouts that are taking place in each sub-county could be resolved only by reshuffling the inventory in that sub-county alone, let alone if we try to sort of move commodities across sub-counties. So because of the existence of data, we did not have to go through the standard route of ordering from suppliers, but we could actually shuffle inventory among health facilities that are providing different levels of service to different populations, and basically be able to sustain the operation and life-saving medications availability, including those necessary for maternal health and obstetric services in these particular sub-counties that had employed that particular software. So that type of example sort of shows how data can be our lifeboat, right? Can be that sort of that medium that could sort of move us to safety. And that was sort of an example that we wanted to build upon. So I just came back from Kenya earlier this week. And what we're doing there, building on that experience, is that we're now ensuring that signals and demand is broadcasted in real time all the way to the suppliers, redistributors, and their vendors. So building on that example and the idea that data could actually save lives, We've expanded the premise on ensuring that the signals coming in from that midwifery, from that particular health facility, level 2, 3, or 4 facility, gets translated into a consumption and a demand signal that is broadcasted in real time into the suppliers' ecosystem. So what suppliers are doing now is that they're pre-positioning this stock in locations that are closer to the facilities to mitigate any climate-related events, or in some cases and in some countries, some security-related events that could disrupt the supply chain. When we have that particular setup, everyone sees the actual consumption, everyone is aware of what the demand is, and therefore that connection creates our ability to resupply that demand without having to sort of be surprised after every climate shock that we're running out of oxytocin or we're running out of that life-saving medication, and it allows us to act earlier. The idea is for us to have resilient supply chains. We need to be prepared for the shock and not act after the shock. And as my colleague here said, you need to have your emergency kit, for example, already pre-prepared, because preparedness is how we prevail in these contexts and in these situations. A wider example, I'm going to touch on this very, very briefly. So a wider example would be us that we've utilized the software as well in a situation where we've had 9 different organizations providing services in about 56 facilities. And the result that they were able to sort of reduce about 40% of the transportation cycles. These are the unnecessary movements of stock moving between facilities for us to resupply every time we run out of a stock. Because with proper demand forecasting, with proper information, we are capable to ensure that these facilities are always in a situation where they can sustain themselves, even if they encounter security-related shocks or climate-related shocks, and especially when we establish networks at a local level that would allow the resupply when these issues happen. So I'll stop here and over to you, Rachel.
Thank you so much, Dr. Yazid, for outlining what a proactive system can and should look like. And I really like that tagline, and something for us all to remember is that the objective is to give the supply chain enough information and enough time to be able to act before the disruption becomes a shortage, and how we can work backwards from that in terms of our planning. So thank you so much. And we will hand it over to our next case study presenter, Dr. Francis. Over to you.
All right. Thank you, Rachel. Please, can you confirm if I'm audible?
Yes, perfectly clear.
Sorry, I wouldn't be able to put on my video because my network is not that strong. I'm not sure my bandwidth to accommodate a video presentation for me. So thank you. Thanks to Dr. Sibinde and Dr. Ayasra for the wonderful lecture and case study. And so for mine, we'll be going over to, I can't see the presentation yet.
I can pull it up for you just 1 second.
Okay. All right. Thank you. So maybe on, thank you. To start off, this presentation is from a study with 2 phases, basic and applied. The basic phase was a formative study that happened in 2025. And the applied phase is currently, it's ongoing as a pilot prototyping of solutions to some identified sexual, reproductive, and maternal health gaps identified during flooding in the formative phase. This case study will dwell on the formative study, and thanks to my colleagues on the project, and special thanks to Grace Kimemia, who supported in putting this presentation together. Next slide, please. I'll be using Adamawa State in Nigeria as a practical case study of what happens when flood is not a surprise event, but a recurrent seasonal disruption. And then just for context, Adamawa State is in the northeastern part of Nigeria, one of the states that was heavily plagued by the Boko Haram crisis. So the question is not simply how did floods disrupt services? Rather, the more useful question is how did women, providers, communities, and supply chain actors keep care going all the same? In recurrent flooding, maternal health continuity is not achieved only by restoring service after disruption. And then in this case study, we will want to focus on how recurrent flooding limits access and utilization of sexual, reproductive, and maternal health services. We would also want to see how recurring supply chain barriers and how they influence service continuity. And then lastly, what were women's alternative to meeting their SRH needs, including self-care practices. Next slide. Climate-related floods can damage infrastructure, restrict mobility, disrupt the supply chain. We've seen all of that in presentations that have happened prior to this. And then sexual reproductive maternal needs for women and girls also increase during flooding. They don't take a pause, rather they include during flooding. And then we know that particularly sexual reproductive health services are vulnerable. We know that these are services that need repeated visitation of women and girls going to the facility. And then all of this is affected when flooding occurs. And then women can't have access to those medicines, those private counseling they need, and referrals as well. And then in a humanitarian setting, it's even another layered inequality in these settings. And then life-saving activities should include sexual, reproductive, and maternal health services. The minimum initial service package should be incorporated into services that should be available for women in this setting during climate disruptions. Also to note, floods are not only a transport problem, they are a system problem. They increase health risk at the same time that they weaken the channels through which sexual reproductive health service care is normally delivered. The key point is that medication access during climate disruption is about availability, physical reach, affordability, appropriate use, and the use of trusted service delivery points. Next slide. Now, this was the study approach for the formative study we used. It's a mixed method exploratory study where for the qualitative data, we had interviews and focus group discussion with the listed sets of participants, which included clients, which were women and girls, segregated by age, also health service providers. We also interacted with some supply chain actors, and then implementers of climate related services. And then for this, we used the snowball approach where we approached a particular implementer, and then they tell us of another implementer who is doing something around climate crisis as a response. Data were collected within the space of August to September 2025 for qualitative data. And then for the quantitative data, we utilize the district health information software version 2, which helped us to get retrospective data for the last 3 years. That's spanning from 2023, 2024, and up to 2025. And then for this data we got, it's from this different location. There were 2 local government areas involved in this study, Numan LGA and Fofore LGA. And then in each of these local government, we also had catchment areas, which we refer to research sites that were involved in the study, and there were 4 altogether. Next slide. And then for the data we collected for the qualitative data, thematic analysis was done after data was cleaned and stripped. Grouping was done based on themes, and these themes apply to the different phases of the flood, before the flood, during the flood, and then after the flood. And then for the quant data, as I've mentioned earlier, data was collected from the DHIS2 software. And then it was across 4 locations that I've mentioned earlier, and then across 4 themes within sexual, reproductive, and maternal health. We collected data that had to do with antenatal care, delivery, facility-based deliveries, postnatal care, and then family planning services. And then for this data, we disaggregated the data into 2 components. We looked at data within July to September of each of the year as data that apply to the flood periods, because these are the months in which flood happen every year within those communities. And then data from months outside July to September, we regarded as data that had to do with the non-flooding months. Next slide. Now, after our analysis, these are some of the results that are highlighted in this presentation. Here, the heading says, when flood comes, women cannot reach care. Yeah, we got to see from the analysis that the impact of floods on pregnant women having their routine checkup was not uniform across the 4 location. However, there was decrease in ANC attendance in most of the location, 3 of the locations, and then just 1 of the location had an increased ANC service during the flooding period. And then we also discovered that for the area that had the increased ANC data during flooding, from qualitative engagement, we got to understand that those areas, the service provider employed some good techniques, some recommended technique where they had to go out for community outreach using rain boots, raincoats. They had to go on canoes into communities where women could not come to the facility, and then they did outreach services for ANC. That's why we see that. But for in communities where women did, where providers did not go the extra mile, we also in those communities there were decreased ANC participation, which means that women missed their checkups to ascertain and then be sure that their pregnancies are okay. And then because of this also, fewer women reached the clinic to give birth, so more home deliveries happened during the flooding period. Next slide. Now, when flood comes, road close, we cannot overstate this, facilities shut down, the costs rise, because in these locations, we saw that some of the challenges that were experienced was that some of the facilities were not submerged, but the access routes to get to these facilities were all flooded. So even while the facility was there, and women and girls could not access this facility. Why for others that there were some access to the facility, but the facility itself was submerged in water. So the different location had their different presentation of what the challenges were as far as flood was concerned. But one common thing that happens in this period is that there is access collapse, where either road, as we've mentioned, cannot be accessed, or the facility itself is flooded. And then women were falling back to informal care just to meet their needs. And for women who were delivering at home, they utilized traditional birth attendants to have their deliveries done at home. For patients who needed one form of antibiotics for whatever challenges they were facing, turned to unregulated points to actually assess those medications they needed. And some even resorted to the use of herbal medications as well. Only delivery at this point were treated by women as an emergency, but every other sexual, reproductive, maternal health need they had to put it on hold, irrespective of how it was affecting the quality of their lives till services was restored in the facility. And then some of the clinical consequences we saw was that there were stillbirths happening at home, postpartum hemorrhage from births happening at home without uterotonic introduction to prevent PPH. Newborn had their own share of the consequences, as we saw a lot of babies who were coming down with pneumonia. There were also miscarriages from women coming down with severe malaria. And then unintended pregnancies were also said to have happened in the community, and people even narrated their personal, their experience in this regards. Some of the quotes we got was two quotes from different adolescent ladies in different research sites. One said, "I was in labor during the last year flooding. All the roads were submerged. The traditional birth attendant said the delivery had complication and that could not be handled at home. So we had to take a canoe across the water to the clinic in Yola Town." Yola Town is a secondary facility, but in this situation, to get to Yola Town, they need to cross over large expense of water in canoes without protective wears like the life jackets. They had to go all that way out. Another adolescent lady mentioned that the inaccessibility of going out for my ANC was what caused me to have a miscarriage. The inaccessibility issues are too much on us because we don't have good roads. It complicates our pregnancy experience. Next slide.
Dr. Francis, I'm sorry, I realize we're almost out of time. Would you be able to wrap up in the next 30, 60 seconds or so?
Okay.
Thank you so
So,
much.
all right. So these were other quotes we got. Now to this, we also noticed that most of the delivery, as I've mentioned earlier, that happened at home had no access to any form of uterotonics. Why those at the facility, we can see the statistics there. So women suffered from complications, including excessive bleeding. And then for our current study, we are also testing how distribution of heat-stable misoprostol would help women to prevent this. Next slide. Yes, here this slide is talking of what are those challenges, and here I would just want to mention something very critical, which is in cases of emergencies when it has to do with crisis, what do you call it, climate crisis. One thing we must understand that the last mile delivery is no longer the PHC, the primary health care center at the community level, if people can't access the health facility in times of flooding, but rather the last mile delivery is in the patient's house where they can actually do some self-care practices to actually meet their own health need. And as far as these commodities can't get to them at home, then the last mile has not been reached. Next slide. And then this is just highlighting what Dr. Sibindi presented, where she said family planning had was within the middle risk. Yes, ANC, this study also showed that ANC and delivery services suffered more decline in utilization than family planning, and then some form of self-care is already existing in family planning area, which made women to have access to these services. Next slide. Here, I would just like to state some of the things women used. A comment here was saying that I also used herbal and traditional herbs and it works well. But herbs cannot treat every sickness, so sometimes it fails. So we have to go back to the clinic in Yola town. So these were the different ways in which women cope. So can we just go to maybe the last two slides where I would read up. Okay. So recommendations. What are the recommendations we are proposing, especially for humanitarian setting? Because I know most of the presentation probably didn't talk about that. Institutionalized flood preparedness in SRH planning and budgets. Invest in decentralized commodity hubs and resilient supply. Build capacities of resource community structures so that their roles are incentivized and these people can be utilized when it is hard to use the formal setting. And then also make sure self-care routine policy is not an emergency, but a constant that people can be in touch with, and when crises of this nature arise, and they have those skills to take care of their needs. Next slide. So the last two slides here is just showing us what we used with the gap circle as an analysis to prototype and design the prototype we are currently using. These are the gaps that talk about what were the problems, who were the key actors, where women access services, and when do they get these services. With that, we're able to use the what in this gap circle to have a prioritization section with women where they identified 4 major problems that they would want the prototypes to address, and then the who, where, and when gave us the idea of when do we pre-position stock in anticipation of the floods to come, and then in what method is it best to do that. The last slide. And then with the gap the flood gap analysis we did, and then the design, we're able to bring out this prototype, which we are currently implementing. Advanced misoprostol distribution for women using the last reliable contact before the flood sets in, so that these women get this drug and then pre-position it at their homes and are able to use it to ensure that they don't have excessive bleeding during delivery. And then we also give out advanced distribution of Fancida to ensure that when flood cuts access to facility, these women at home are able to continue to use this drug every 4 weeks to ensure that they don't come down with malaria. And then we had a prototype also to manage genital infection, which is on the increase during the times of flood, and then life jackets to help women to add to the safety for women when they cross from one point to another to seek care. Thank you. I would stop here.
Thank you so much, Dr. Francis. I think you did such an excellent job at exemplifying all of the challenges and also the solutions that we talked about today and the importance of meeting communities where they are in trying to mitigate both the clinical cascade from these crises and hazards, but also some of the other socioeconomic challenges that come with that. So thank you so much. Everyone, I realize that we are over time. I appreciate you sticking with us. Um, Apologies, I couldn't see the chat either. There was a lot of great Q&A questions that came in, but we hope that the resources that we'll share following this event will help to answer those questions, and please do reach out to us for any follow-up, as well as the presenters. And I just want to give a final thanks to all of our three presenters today for their great insights. And we thank you so much for participating. We will see you next week. Bye, everyone.